Hi, we're going to be discussing neonatal tetanus. Neonatal tetanus is said to be the occurrence of tetanus in a newborn within the first 28 days of life. Tetanus is said to be an acute paralytic paralytic illness caused by neurotoxin of Clostridium tetani. And Clostridium tetani is said to be a motile gram-negative spore-forming, non-capsulated, non-invasive obligate anaerobe bacillus, which is rod. The habitat is in the soil, in the dust, in the alimentary canal, and also in the human feces. The alimentary canal of animal and in human feces. The spore, they are terminally located, giving a drumstick or penis racket appearance. The exotoxin, called tetanospasmin, is a neurotoxin manifesting the disease and tetanolizing. Tetanospasmin is the second most poisonous substance known and surpass potency only by botulinum toxin. Sources of infection: neonates, contamination of the umbilical cord stump following unsanitary delivery coupled with a lack of maternal immunization. Older children, either by hairpiercing, circumcision, dirty wound, otitis media, and the rest. Epidemiology: neonatal tetanus account for about 500,000 to 800,000 neonatal deaths globally, 80% of which are in Southeast Asia, Africa, Eastern Mediterranean countries. In Nigeria, incidence ranges from 14.6% to 20% per 1,000 live births. Incubation: infection to first symptom. Neonatal tetanus takes 3 days to 14 days after birth, average of 7 days. Non-neonatal tetanus could be 3 days to 21 days. The period of onset is the period between the first symptom and the first spasm. Pathogenesis: following the introduction of the Clostridium tetani spore to an injury site, the spore, under low oxidation reduction potential, germinate into vegetative bacterial cells. Tetanospasmin and tetanolizin are released after the organism dies and lies. Tetanospasmin travels from the injury site towards the spinal cord and brain stem in the exoplasm of the alpha motor neurons. The toxin exits the alpha motor neurons to enter the adjacent spinal inhibitory interneurons, where it inhibits release of inhibitory neurotransmitter glycine and GABA aminobutyric acid. Tetanospasmin achieves this by cleaving the protein synaptobrevin, which is involved in binding of vesicles containing glycine and GABA towards the cell membrane for release. Consequently, glycine and GABA are not released, causing loss of inhibitory actions of the higher centers on motor and autonomic neurons of the spinal cord and brainstem. Thus, affected patients develop maximal muscle contraction without relaxation, as well as features of autonomic dysfunction if severe enough. Clinical features: sudden inability to suck due to trismus caused by masseter muscle spasm, restlessness and irritability, neck muscle spasm and difficulty in swallowing, sustained spasm of facial muscle, rhizos sardonicus, generalized muscle spasm and stiffness, or opistotonus, laryngeal and respiratory muscle spasm causing apnea, asphyxia and cyanosis, bud-like rigidity and of abdominal wall and muscle, bud-like rigidity of the abdominal wall and muscle. Autonomic dysfunction includes fever, tachycardia, labile or sustained hypertension, excessive sweating, cutaneous vasoconstriction, cardiac arrhythmia, and the rest. As tetanus does not affect sensory nerve or cortical function, the patient characteristically remain conscious, except when complications are set in. Management, you have to take history. Your history includes your biodata, history of tetanus toxoid in pregnancy, if the patient or the mother took tetanus toxoid during pregnancy, and place of delivery, history of birth trauma, delayed history of cord care, history of history to determine incubation period and period of onset, history around other clinical features and complications. The physical examination, detailed general and systemic examination looking out for signs and complications of the disease highlighted above. Investigation, diagnosis of tetanus is mainly clinical. Routine investigation are usually normal. Full blood counts may show leukocytosis in a secondary bacterial infection of the wound due to stress or sustained tetanic spasm. Lumbar puncture usually normal except for increased opening pressure, especially during spasm. Serum muscle enzyme creatine kinase aldolase may be elevated. Electroencephalogram or electromyogram does not show characteristic pattern. Wound sub MCS, tetany is isolated in only 1/3 of cases. Serum electrolyte urea and creatinine might show abnormal, might be abnormal in acute renal failure. Blood glucose could be low when complicated with hypoglycemia. Treatment: neutralization of circulating toxin, 500 international units of human immunoglobulin, of human tetanus immunoglobulin, or 10,000 international units of equine or bovine anti-tetanus serum is sufficient to neutralize systemic tetanus toxin. About 15% of patients develop serum sickness with anti-tetanus serum. Dose administration must be 30 minutes after an unreactive test dose, in brackets 0.1 ml of 1:100 anti-tetanus serum intradermally. 0.1 ml of 1 in 100 anti-tetanus serum intradermally. Now, control the spasm and continuous sedation. Diazepam, which you can give 0.1 to 0.2 milligram per kg per dose 4-hourly intravenously, titrated to patient response. Then effective alternative could be lorazepam, midazolam, vecuronium, pancuronium, phenobarbital, baclofen, dantrolene, chlorpromazine. Elimination of residual clostridial infection. Debridement. After patient is stabilized, wound debridement should be done. Antibiotics like penicillin G, 100,000 international units per kg per day in 4 divided doses, IV intravenously for 10 to 14 days. Metronidazole 7.5 mg per kg 8-hourly, IV intravenously for 10 to 14 days is equally effective. Now, adequate fluid intake and calorie intake. Feeding is with expressed breast milk. Via nasogastric tube. Oral feeding is contraindicated to prevent aspiration, optimal fluid and electrolyte management, optimal nursing and good supportive care. Patients should be on bed rest in a room that can be kept dark and quiet, preferably an ICU intensive care unit. Prophylactic intubation or tracheostomy patient is at risk of laryngospasm. Regular repositioning. Regular repositioning. Regular repositioning of neonates at feeding times to prevent pressure sores. Then oxygen administration via face masks is if the SpO2 drops below 92%, then close monitoring of the vital like temperature, pulse rate, blood pressure, respiratory rate, gentle suction of the nasopharynx is necessary. Management of the autonomic nervous system or autonomic dysfunction, only intravenous esmolol is currently recommended as beta blocker can cause hypotension and sudden death. Vaccination of survivors. As a lethal dose of tetanus toxin 10 raised power minus 5 mg per kg less than the immunization dose, natural infection does not confer immunity. Thus, survivors should be vaccinated with tetanus toxoid 0.5 ml intramuscularly prior to discharge. Complication of neonatal tetanus. In the nerves, it could be seizure, coma, nerve palsy, hypoxic brain injury. For respiratory, it could be aspiration pneumonitis, orthotaxic pneumonia, pneumothorax, pulmonary embolism. In the gastrointestinal, it could be stress ulcer, gastric dilatation, paralytic ileus. In the renal, it could be acute renal failure, urinary retention. In the metabolic, it could be hypoglycemia, metabolic acidosis. Hematology, could be deep vein thrombosis. Musculoskeletal could be pressure sores, rhabdomyolysis with myoglobinuria, intramuscular hematoma, fractures of the spine or long bones. Poor prognostic factor could be short incubation period, short period of onset, presence of fever, poor supportive care, portal of entry close to the CNS, unprovoked persistent generalized spasm, metabolic acidosis, presence of autonomic functions. Prognostic grading system is the Hendricks, the Phillips, and the Ablett. Prevention, vaccination of pregnant women and all women of childbearing age, discouraging harmful cultural practices about cord care and scarification, ensuring births under hygienic condition, prophylactic anti-tetanus serum for high-risk neonates, training and retraining of caregivers and birth attendants. Differentials include parapharyngeal abscess, retropharyngeal abscess, intracranial hemorrhage, dental abscess, trachea, poisoning, meningitis, and rabies. Thank you for watching my video to the end. Please like my video, subscribe to my channel, and share to your friends. See you in the next video. Thank you.